The theme for this year's symposium is really looking at occupational health. How do we protect ourselves while we are at work? Some of you may not be at risk, but there are some people whose risk is heightened. So these are the people that we really want to speak about. What should we do? And what risks do they face? And what mitigations are available in our country? So as the slides come up, I want to say that my presentation is not scientific, so there is no science, but it's a call to action. It's a call to action because all of us at one point maybe or may have a relative or even one of your children may find themselves in such a position. At the Lung Institute, we receive patients, and when you dig deep in their history, you get interesting findings that may have primarily put these people's lungs at risk of developing the clinical situation they're in at the time that they're presenting. So my name is Ivan Chimuli, like Dr. Baluku has presented, and on behalf of the Air Quality and Environmental Health Research Group at the Makerere University Lung Institute, I would love to deliver this presentation on understanding the interplay between air pollution and occupational health. Okay, so how do we define air pollution? So this is a complex environmental issue that is characterized by the presence of harmful substances in the Earth's atmosphere. And these substances are often referred to as pollutants. So when somebody talks about air pollutants, these are the substances that are in the air that we are breathing in. And they can originate from many sources, some of them natural, some of them man-made, and these lead to adverse effects on both the environment as well as the human health. So when somebody talks about airway, or rather air pollution, what they mean is that these substances are in amounts that are harmful to the human body. So recognizing the importance of the interplay is really essential, and it's not an academic pursuit. Like I said, this is a call to action to employers, to policymakers, to every stakeholder that is here and beyond, to ensure that our workplaces are safe for the people that work in these places. Okay, so if we are to look at the sources of pollutants or sources of emissions and the occupational exposures, they are quite varied. And as the panel noted in the morning, they come from literally very many industries. So yesterday, I and a group of members at the MLI, together with a group of students, medical students, I know most of them are here, so thank you very much. We held a community awareness activity that went into the community to the people that we feel are at risk of exposure while at work. This included people who are on the streets. People who are on the streets, we have traffic officers or transportation and logistics people. We have the sweepers. And for some of the pictures in here, you can see some of us trying to talk to the sweepers. This was around the roundabout. We have the traffic officers the other side. We were also able to go to a milling place in Chisenyi, because as you know, these are the people that are exposed as they are working. And you know what is interesting? The comment that was made earlier on in the morning is indeed true. When we went to this carpentry, there's a carpentry there that we went to in Chireka, we were able to find the owner of the business. And fortunately, we had primed him that we would be coming. But he confessed and said, you know what, doctors, these people actually know, and I provide them with these masks so that they can protect themselves while they are working. but they actually do not wear the masks. So it's a very disturbing position. We don't know how to go about it, but we think that with you here, with the advocacy that we can create, maybe people will actually take it upon themselves. So it's not going to be only the employer, but a personal responsibility as well that is needed. So people in the traffic and transportation, indoor work environments, the millers, the people that are working in kitchens that are indoors, these guys are continuously exposed to air that is not clean, and therefore putting their lives at risk of air pollution-related conditions. Next slide. So what are some of the health effects that have been observed following air pollution? They are quite varied, and they are multi-system. So we cannot complete the list if we are to start. But more importantly, and because we are from the Lung Institute, we really were interested in respiratory disorders. So there are quite a number of respiratory disorders that can come from air pollution. But it is even very disturbing that people who have pre-existing lung conditions are at a heightened risk of exacerbation of those pre-existing lung conditions. And so it is important for us to know where we are going. So the people who have pre-existing lung conditions are at heightened risk. But these guys are at risk of furthermore disorders, bronchitis, lung emphysema, and even the cancers that Dr. Mbabazi, the radiologist of Uganda, has been talking about. But that said, we have other non-communicable diseases that have been observed to emanate from exposure to air pollutants. Circulatory diseases, hypertension, ischemic arrhythmias, heart failure, arterial stiffening, blocked blood vessels. This morning there's a young man who died, and on the group someone asked, is it possible that we can explain these sudden deaths recently? Who knows? Maybe it is air pollution. Okay, don't forget the vulnerable groups. As employers, we know that there are some groups that are vulnerable to air pollution. These include the workers that are high risk, that are pre-existing with health conditions, pregnant women, as well as aging workforce. And I don't want to talk much about the aging workforce because many of us in the workforce are aging, but there is something about the aging workforce that you people need to be careful about. So as you're employing people, be sure that there is something about them. Their immunity is waning, and there's something about their protection that is key. Do we have regulatory standards in this country? The panel in the morning tried to extensively go through a possibility that we need to take care of ourselves. The team at the Ministry of Health, the team that in the labor force that is looking at occupational health is thin on the ground. But do we have regulations and standards that we are following? The biggest legislation tool that we have in our country is the Occupational Safety and Health Act of 2006. But particularly for the air quality standards, we have what we call the National Environment Regulations of 2022. I was talking to the commissioner after his presentation. And I asked him, why is this not here yet? NEMA says this has been drafted, it has been completed, it is pending signatures. Dr. Kamara, it is pending the signature of the minister. I don't know if this is something that you can help us. The president, no, this you don't require the president, it's just a guideline. So can we have this sorted and available? I mean, this talks about what we should expect as emission limits for the different pollutants in the different industries. It gives us the best use of practicable means and technologies, provides adequate ventilations for, and then puts in place safety signages that would be important for all employees to utilize while they go on with their jurisdictions. So this is not a case study at a workplace, but it is a case study that tries to highlight what the air pollution levels in our country are. So a case study, and this was done by Chirenga and others in 2015, They wanted to look at the pollution levels of PM 2.5, that is particulate matter 2.5, in 2 districts in Uganda, that is Kampala and Jinja. And I can summarize it for you, and I tell you that industrial areas with locations, also with areas that also have locations that have unpaved roads, had very high PM 2.5 concentrations compared to areas that were not industrial. So industry is a huge, huge contributor to the pollution levels that we have in our country. Next. So how do we do monitoring and assessment? We do have methods of assessing air quality in workplaces, and these include ambient air quality monitoring, personal air monitoring with personal monitors. We have real-time monitors and indoor air quality monitoring. So these monitors are available in some places, but not in every place. As the other thing is that we also need to perform periodic health assessments for workers. This was highlighted in the morning, where we need to perform respiratory function tests. We also need to detect some of these biomarkers in urine and blood, as well as general health checkups that are looking at how these patients are performing, or these employees are performing. So what are some of the mitigation strategies that we have? I think it was the commissioner who also talked about the engineering controls. So we have engineering controls, we have administrative controls, personal protective equipment, which he said was the last or the least of the protective mechanisms, as well as workplace designs. I remember during COVID, we walked around health facilities, and we actually realized that even hospitals are at risk, simply because of the way the places are designed. But try to think about rotating jobs or rotating stations when you have employees that are exposed, training them and educating them, and scheduling. So not everyone is supposed to work every day for 7 days, Monday to, or rather 8 to 8, as some of the industries are actually doing. So as I wind up, I want to talk about the future trends. So in air pollution, what are the future trends? Is there something that we can do different? Lately, we have seen AI coming in, and we are being told that if we are able to take on smart monitoring systems, integrating AI and sensor technologies for real-time monitoring of the quality of air that we are breathing in, this may change and help in protect the health workforce, or rather the workforce. Innovative filtration technologies that filter some of the chemicals out of what we actually have to use. Green technologies, I think you've seen people that are advocating for green roofs, green walls, and some of the hotels, maybe I've not seen one yet in Uganda. I think, is it probably the hotel at 4 Points? But green roofs and green walls, because that is a natural filter for most of what is polluting the environment. Effective regulations and standards, and we should be ready to change. What we have now may not be helpful 10 years from now. So we need to effect these regulations and make sure that we also engage in research and innovation. So we need to look at ourselves and say, are there any biomonitoring scientific methods that we can use? Are there some biomarkers that we can utilize to see which people have been exposed? And can we follow these so that we are able to truncate their exposure? Health surveillance technologies, wearable technologies for people especially that are exposed. And of course, we need interdisciplinary approaches. No one is going to do it on their own, alone. So as I conclude, I just wanted to walk through the summary that we've looked at the diverse sources of air pollution, the vulnerable groups, monitoring and assessment, as well as the mitigation strategies. Now, continued awareness and proactive action are essential. So staying informed, advocacy change, as well as investing in innovation, which is part of my call to action for air pollution, are key things. So let us remain vigilant in our commitment to occupational health in the face of air pollution challenges. I don't have, I wanted to show this picture for the team that worked with us yesterday. This is a team that went to the community, including my director there. So thank you very much. Chair, back to you.
Yes, another round of applause for Dr. Chiri. Yeah, one day when I become important like you are, I will shift from Chisenyi and join you in upscale Kololong to avoid air pollution. Now, the intercourse between air pollution and tuberculosis is very disastrous. And therefore, I'm going to invite Ivan Ahimbisiwe, who is a clinical epidemiologist, and he will briefly tell us about the prevalence of pulmonary tuberculosis among casual laborers who are working road construction sites in Uganda. A round of applause to him.
Good afternoon, good people. My name is Ivan. I'm a graduate of clinical epidemiology and biostatistics from the CEU and the School of Medicine. Professor Nelson Sewankamba was here, and when Professor Bruce was talking about intentional capacity building, I was looking at Sewankamba because we are a product of his ideas. I don't know if my presentation is ready. The lady from Mubenda was asking if there is a plan to eradicate TB. This country is serious about eradicating TB. We even sent 2 delegate groups to the UN on 22nd of September this year to represent Uganda about ending TB. The plan goes up to 2030, but there is a 5-year work plan. And in that 5-year work plan, on the first annex is a multi-sectoral accountability framework for TB, which my work does about. I'm glad that the Honorable Member of Parliament is here. Dr. Charles gave us a leeway to use your door if we have any policy issues that we feel are not being addressed. Workers, no, go back to the heading. Where have you put the prevalence of pulmonary tuberculosis among casual laborers working in road construction sites in central Uganda? Road construction workers have been a neglected population, subpopulation, when screening and diagnosing for TB, yet at high risk. Workers with occupational exposure to respirable silica dust, such as casual laborers at road construction sites, are known to be at high risk of developing PTB. There's limited literature about this, the burden of PTB among this subpopulation, yet with high occupational exposure to silica dust at road construction sites. Professor Olodia talked about the crystalline silica that is contained in rocks that we use to get gravel for making these roads. And he also exposed the extent of developing TB for people who are exposed to silicosis. It's about 90%. We aim to determine the prevalence of PTB among casual laborers working at road construction sites in central Uganda. We enrolled 297 participants by consecutive sampling into a construction study between the 1st and 30th of September 2022 at 4 road construction sites in 4 districts in central Uganda. The road construction sites were both Tamak and Malam. A structured questionnaire was administered, and the PTB cases were identified using the gene expert and an AI-powered computer-aided detection for TB, chest X-ray machine. Data were analyzed in starter version 17. Descriptive statistics adjusted for clustering were used to summarize data. A mixed effects modified partial regression model was also used to estimate the adjusted prevalence ratios in search of the relationship between PTB and the leveraging factors. The results, most of the participants were males. The median age was 29 of the working group or sites. Prevalence of TB among these casual laborers was 2.4%. 2.4%. This is 10 times higher than the national prevalence for TB. No history of BCG vaccination, alcohol use, and staying in overcrowded houses were among the factors that were positively associated with PTB. In conclusion, we're saying that there is a high prevalence of PTB among this high-risk group of casual laborers with no insurance, petty pay, working at road construction sites in central Uganda and in Uganda at large. Individuals who had no history of BCG vaccination, alcohol users, and those staying in overcrowded houses were at a higher risk of developing PTB. We do recommend routine screening of casual laborers at road construction sites to optimize active TB case finding. Now, I need to categorically state that the Ministry of Health came up with a multi-sectoral accountability framework, but the implementation is a problem. And it's unfortunate that the person who had represented the minister from gender left. But Minister of Gender is supposed to coordinate the Office of the President and Minister of Works and UNRWA in making sure that TB prevention and control programs are put in place. Because the money that was allocated to, that's being allocated to TB control programs, according to the MAF TB framework, is the money that is being channeled to HIV/AIDS. But most projects take into consideration programs for preventing and controlling HIV, neglecting TB. Yet the two are comorbidities. So that was why I was telling the MP that we need their help on this to integrate the policy and work together in utilizing the little resources. So there's always a 10% funding for every project allocated to cross-cutting issues, but the 10% funding is being biased. The Office of the President has left it to HIV programs. TB is being neglected. Thank you.
So I'll start it off with a study that measured the impact of socioeconomic factors on tuberculosis treatment outcomes in northeastern Uganda. It was a mixed method study and it was conducted by a team that is highlighted there. So just to give you a brief summary, we know that TB is a major problem globally, causing more than 10 million incident cases worldwide. And there's been a link with socioeconomic factors. We know that TB is a disease of poverty. And when we look at this image, that image really just summarizes several socioeconomic factors that interplay with TB, all the way from exposure, infection, active disease, to the consequences that we get after TB. I'll just emphasize poverty and low socioeconomic status right there in the middle. And when we look at the map of Uganda, we see that the poverty levels in Uganda really concentrated, vary across the country. But when we look at the darkest area in northeast Karamoja, it really points us to think about this region, because as of 2018, it was one of the poor performing areas nationally, with a low treatment success rate of about 48%. In the last 5 years, we've seen a positive trend in TB treatment success rates. Currently, nationally, they are at about 88%, including Karamoja. So we've seen this upward trend, but when we conducted this study, we really wanted to look at that particular region. So TB treatment is of course important, because after we've identified the TB cases, we want to initiate people on treatment and make sure that they achieve good treatment outcomes. And as we can see, as of 2023, the recently concluded UN high-level meeting has set a target of treating around 45 million people. I'll just end with this last image that really summarizes the 2018 targets. And we can just see that we reached about 34 million of the targeted 40 million as we look at that new target. So the aim of this assessment was to assess the relationship between social determinants of health and TB treatment outcomes. So this was a mixed methods assessment in Karamoja. We used convergent parallel methods. That means we collected both qualitative and quantitative data at the same time. And I've highlighted why we focused on the Karamoja region. So the quantitative methods really wanted to establish the magnitude of association between the socioeconomic factors and TB treatment outcomes. So this, we enrolled patients who had already completed treatment. So we enrolled patients into a retrospective cohort. We randomly selected 313 former TB patients, and we used a ratio of 1 to 2 for successful versus unsuccessful treatment outcome. And we got these patients from the community. We collected social demographic data. We also used wealth to measure their socioeconomic status. Given the economic activities in the Karamoja region, we thought this would be a better estimate of economic status than how much money do you earn in a month. We also looked at pre-treatment loss to follow up in 3 of the 10 diagnostic units. We also wanted to understand how to get perceptions on how conditions of daily life and healthcare system factors acted as barriers or motivators during TB treatment. So for this, we invited patients for focus group discussions and 18 key informant interviews among healthcare personnel, and these were at various levels of the healthcare system. So just to summarize some of our results, our analysis really focused on grouping this. We use principal component analysis to group these patients into 5 wealth quintiles, with quintile 1 being the richest and quintile 5, sorry, in this case being the poorest. So when we went to look for the patients within the community, of the 313, we were able to get 264 respondents. And when we look at unsuccessful treatment outcomes, we see that 40.4% of patients had unsuccessful treatment outcomes in quintile 1. Oh, sorry. So quintile 1, sorry, had an unsuccessful treatment outcome of 40.4%, sorry. And in quintile 5, which is the poorest, we say that the odds of getting a successful treatment outcome was 0.4%. So this group had lower odds of getting good treatment, or of getting a successful treatment, and this was the poorest group, as I've mentioned earlier. So when we look at the curve, the concentration curve, that's image C, we expect 40% of the population, for example, to have 40% of the unsuccessful treatment outcomes. But when you look at the blue line, it shows that it deviates just slightly from the line of equality, and it's deviating upwards of the line. So I know this is an image that is not usually seen. It's a concentration curve, and this really shows that unsuccessful treatment outcomes are distributed in a proper manner. That means it occurs more among patients who are poor. So this is a session that's really looking at occupational risk. So one of the social demographic characteristics that we looked at was employment, employment of the patient and employment of the household head. So we see that formerly employed household heads had lower odds of unsuccessful treatment outcome, with an odds ratio of 0.19, and this was significant with the unadjusted analysis. Then when we did multiple logistic regression, we had 3 factors that remained significant. As I've mentioned, quintile 5 had remained with an odds of 0.42, and this was significant. Adjusted odds of unsuccessful treatment outcome. Then we also had a significantly higher odds of getting an unsuccessful treatment outcome among children under the age of 15 who were not school going. And additionally, when you ask them if they were participating in any economic activity, there were none. So we categorize this as children who should be in school but were not school going and were not formally employed. And also we had more unsuccessful treatment outcomes among people employed in the informal sector. Lastly, we found that about 256 of the bacteriologically confirmed patients in 3 health facilities in which we wanted to look at pre-treatment loss to follow-up, of these, about 17% were lost to follow-up before the first pill. They did not take the first pill of TB medication, and this is what we have quoted as pre-treatment loss to follow-up. And we can see that this was higher in females than males, at 21% in males, 21.7% in males, and 13.5% in females. Karamoja has nomads, so we wanted to look at seasonal variation. So this image just shows that between the months, TB detection was variable. And if we look at patients who are initiated on treatment in red, and those who are lost to follow up in yellow, we see a similar seasonal trend across the years. This is something that we're not able to establish the factors behind it, but we clearly saw a trend across the years in TB detection and pre-treatment loss to follow-up, being lowest in the months of November to around February. So from the discussions that we had with the patients and the healthcare workers, we were able to identify barriers and motivators for treatment at the interpersonal, and environmental level. And I'll just emphasize, as I showed you in the first figure, this is an area that is the most socioeconomically deprived in Uganda. So barriers such as lack of food during treatment, especially for patients on medication, was very important, and this was highlighted by the healthcare workers and the patients. Stigma came out, and as we mentioned, it has a migratory community. So migration in search of food, pasture, water, mining activities came out during our interviews. And when we look at the motivators, patients really attributed the benefits of taking medication because if you've interacted with TB patients within 2 weeks, the medication really has an effect and they're able to improve. And this is some of the quotes that we got from our patients really talking about improvement once they started medication, strong NGOs and support systems within the region, particularly among the healthcare workers, and also community engagement. So in conclusion, we found that socioeconomic status significantly affected TB treatment outcomes, and there was a 58% reduction in risk of unsuccessful treatment outcomes among participants in the highest quintile. There were higher odds of unsuccessful treatment outcomes among people employed in the informal sector and children under 15 who are not in school or employed. And based off this study, we recommended social protection incentives and enablers for all TB patients, community engagement, and same-day TB treatment initiation to really reduce the pre-treatment loss to follow-up rates. I'd like to acknowledge MLI, the NTLP, and QAM, who led and participated in this assessment. Thank you.
So I would like to take this opportunity to invite Mr. Boye, who is going to take us on a presentation on overcoming disruptions to healthcare delivery systems, lessons from TB programming during the pandemic. Thank you very much.
I would like to first present on the left, the global disruption following the implementation of the mitigation measures to respond to COVID-19. As you see, just after 2019, as we went into 2020, there was a slight decrease in the number of TB cases notified. And this was attributable to the different mitigation measures instituted to control the pandemic. This one, I break it down with the different continental notification trends. As you see from the African or the region of Americans or the Southeast Asia, there was a big downward trend in the TB notifications following the pandemic. Next slide. So looking at the WHO and TB strategy milestones pre-pandemic and during the pandemic, we see that mainly I highlight the deaths. By 2019, we had moved at least 14% in the reduction of deaths against the 35% target. But this was reversed to 9.2% in 2020. And this one was a huge disruption. So this may not be seen in the TB incidence rate, but we see that the increase in the TB incidence, which target is 20%, did not increase as much from 2019 to 2020. And this is the same with the reduction in the percentage of people with the TB catastrophic costs. So coming to Uganda, what did we see? We saw a huge 17% drop in notified TB cases due to COVID-19 lockdown. And remember the restriction in movement, stigmas due to severity of TB and COVID, the healthcare workers perceived of infection, and also the repurposing of the different TB care and diagnostic resources to COVID-19 care. Next. So I would like to present work that has been done by us at the Lung Institute, working with the different partners, called the TB COVID study. We conducted this work in 6 health facilities across the country, Mubende Regional Referral Hospital, Chiboga General Hospital, Chisenyi, Mulago, and Jinja. And the aim was to describe the characteristics of patients attending TB care during the COVID-19, the different phases of the COVID-19 pandemic. And this was a mixed method study. We compared different levels, or different phases. Pre-lockdown, which was January to March 2020. During the lockdown, the first lockdown, April to June 2020. Then in between the post-lockdown, July to September 2020. And also, we also brought data from the 2021 lockdown. From the findings, we conducted over 672 phone interviews. 60 of these were male, with an average age of 30 years. So the significant high proportion of patients reported a barrier to TB care during the COVID-19 pandemic and pre-pandemic, and this was at 79% compared to 68% pre-pandemic. So going down into the in-depth interviews, we saw that there were a number of barriers, including the limited measures of transport, the lack of money, the policing authorities really limited, created fear among patients to go and visit the health facilities, either for diagnosis or for refill, the fear of COVID-19 infection, but also the TB COVID-19 similarities in symptoms also created fear in that people thought they would ambulance them, as you saw. The other thing that I could talk about is that we saw the fear of healthcare workers catching COVID-19, because for sure they didn't know what they were treating, and because there was limited diagnosis, but also the availability of healthcare workers. This work, as you see, we submitted it to BMC Public Health, and we've responded to all comments. It will be out so soon. The other findings that we see is that more males missed TB care visits during COVID-19, the lockdown period, compared to females. I don't know why, but we are investigating more. We shall be sharing more of these. But also patients that, for example, data that we analyzed from the urban centers, mainly Kampala, patients who resided outside Kampala found it very hard to come for a refill where they had been diagnosed or where they were taking treatment within Kampala. And this was a big barrier. I would like to compare our results to results from Ethiopia. We're seeing that results from Ethiopia still show that the pandemic also had a negative impact on TB care, as you see, the different access to TB care, the detection of by community, detection of TB care by the community, and the different stages of the TB care cascade were all halted, all probably disrupted during the care. And this highlights the importance of reinforcing TB care services, including advocating for alternative digital health technologies, mainly to screen for TB during these settings. I would also like to compare with the results from an upper income country like Italy. We see that patients in the cohort comparing with patients coming to health facilities in northern Italy, March to April 2019, and during the COVID-19, March to April 2020, we saw that there was a decrease in patients in the cohort, both 2019 to 2020, but also new TB diagnosis. There was a significant decrease in patients coming for TB diagnosis. Also, there was a decrease in patients that are engaging in TB care. Also, the lost follow-up increased from pre-pandemic, which is March to April 2019, comparing to the pandemic period. And also the deaths increased. This shows that the TB services require urgent need to identify novel strategies to ensure that there is continuum of TB care, but also the implementation of video observation therapy probably go a long way in limiting this disruption. But also we need to orient clinicians reporting regarding the overlap of the clinical symptoms between COVID-19 and TB in this case, but also in case of other disruptions. Next. So from this presentation, the recommendation is that we need program innovations to boost virtual care and support, and this could facilitate continuum of care even during disruptions such as COVID-19 or another pandemic, but also we need to scale up digital health and virtual care initiatives, and this should be tailored to the needs of the people. But in conclusion, the disruptions to health care were evident during the COVID-19 epidemic, and this negatively impacted on the routine TB care and other health care services. There is a need to support continuation or continuity of essential health care services during emergency responses to limit the health care disruptions. And thus, I'd like to acknowledge Dr. Peter Jackson and Dr. Stella Zawede. These are the PIs of the work I presented, and research assistants, the MLI, IDI, but also we received funding from Virginia Commonwealth University in USA to conduct this work. Thank you.
I take this opportunity to invite Irene Najingo to take us on the impact of on-site expert on TB diagnosis and mortality trends in Uganda. I hope you will make a case for expansion of access to expert during your presentation. Let me not bias it. Thank you.
So I'm going to present work on the impact of on-site experts on TB diagnosis and mortality trends in Uganda. So since 2012, TB diagnosis in Uganda has increasingly relied on expert MTB assay. So this test is highly accurate and it enables rapid diagnosis of TB as well as detecting rifampicin resistance. So there was a countrywide introduction of GeneXpert, and we expect that if there is nationwide introduction of GeneXpert, we thought would have better treatment outcomes. So this study mainly compared the TB care cascade at health facilities with on-site GeneXpert testing with facilities that accessed the assay through the specimen referral system, which I'll call the off-site sites. Yeah, so this was a cross-sectional study which reviewed data from the National TB and Leprosy Program, which was captured in the National Health Management and Information System from 2016 to 2019. So a total of 365 health facilities were included for this study. So we adopted the TB Union model, which involves a series of steps for patients to achieve a desired treatment outcome, which is cure or completion. Yes, so the first step of the care cascade, as we know, if a patient comes, it involves the diagnosis, treatment, and as well as the outcome. So for the first step of the cascade was based on the total number of patients, prevalent TB patients at the health facilities. Yeah, so how many patients were presenting with TB. Then the other second step of the cascade was to determine the total number of patients who you actually diagnosed with TB. And the third step was about the total number of patients who died from TB. Yes, I'll use percentages. I know right now people may not be good to capture the numbers. Yeah, so from the financial year 2017-2018, we see that the total number of facilities that had GeneXpert on site. Yeah, so the total number of facilities that accessed which had GeneXpert on site increased from 28% to 50% in the 2018-2019 financial year. Then those who accessed the assay through the referral system reduced from 72% to 50% in the financial year 2018-2019. So we can see by 2018-2019 we had equal numbers of health facilities that had GeneXpert on site and those that accessed the GeneXpert testing through the referral system. Then the total number of TB cases diagnosed, for those that had gene expert on site, there was an increase from the financial year 2016-2017. There was an increase from 62% to 80.8%. Then for those who accessed through the referral system, we also see a reduction in the number of cases from 38% to 19.3%. Then those who are TB and HIV, we also see an increase in the number of cases diagnosed from 66% to 79% for those who had gene expert on site. And then those who had gene expert off site, we see a reduction in the number of cases diagnosed from 37% to 21%. So we can see the facilities that had gene expert on site had more cases, even those that had TB HIV, we see better diagnosis. Yeah, so when we go to the good outcomes, which is cure or completion, we see still an increase from 59.3% to 60.1%. Okay, that is really very small and not statistically really significant. Yeah, so for those who had gene expert off-site, we see a reduction in the good TB treatment outcomes from 66.9% to 56.7%. So when we go to mortality, which was the main really objective, if your gene expert has an impact on mortality. So we can see for those who accessed gene expert, they had it on site, we see a reduction in mortality from 8.6% to 7.8%, while those who had gene expert off-site, we see the mortality increase from 6.9% to 18.8%. And those who had TB HIV, still we see actually an increase in mortality for those who had gene expert on-site. From 58.4% to 61.2%, while those who had gene expert off-site, there was a slight reduction for those who had TB HIV from 63.8% to 60.5%. Yeah, so mainly these are our summary for the results. So we can see facilities that had gene expert on-site, there was an increase in the number of cases diagnosed from 28% to 50%, while those who access through the referral system, we see a reduction from 72% to 50%. And here positively, we see an increase in the number of cases for those that had gene expert on site from 62% to 81%, and also a slight reduction in the mortality from 8.6% to 7.8%. So for those facilities that had gene expert off-site, the number of TB patients diagnosed was 50, reduced actually from 38% to 19.3%. And we also see an increase in mortality from 6.9 to 8.8%. Yes, so we went ahead and did a statistical test to see if there was a difference in the notification and mortality across sites, and really saw there were statistically significant difference. So I would conclude by saying that a wider installation and decentralization of gene expert actually leads to increased case finding, meaning you're able to get much more cases, as we saw that facilities that had gene expert at the health facility had better performance with a gene expert. They had more cases diagnosed. And then we see, however, the impact on reduction in mortality remains limited. Yeah, so as we increase the number of cases, we are able to detect and pick as many TB cases as possible, but there is no really impact on reduction in mortality. We actually saw the facilities that had gene expert on site, for patients who had TB and HIV, we saw an increase in mortality. So we really need to address TB-related mortality, in addition to gene expert throughout, these are required interventions. Really want to appreciate and understand how best can we improve on the TB treatment outcomes, reduce mortality as we keep picking up these cases. Yes, thank you so much.
My names are Samson, that is the preferred. The other one is Omongot, it means a bull, a big bull. It might be very interesting, but yeah, a research fellow in the Lung Institute, and I am a public health specialist. Yeah, so I want to really appreciate you all, and really for continuously being listening to TB, and I'm also coming with the TB. So we are going to discuss on strategies to resolve the gap in adolescent tuberculosis care at 4 health facilities in Uganda that our project embarked on. And so we call it the teen TB. Of course, the teen meaning the teenagers, 10 to 19 years. So in terms of background, of course, we're looking at the data that was available, and more so even looking at the global reports, we realized that there was a gap. And the gap was like, as it's indicated, where in 2021, when we did this study, we realized that 10.6 million people globally were found ill with TB, of which 1.2 million were children. Now, and then about 40% of these between age of 5 to 14 years were missing annually. Then when we looked at still the data in Uganda, we were able to establish that even 44% of the adolescents with actually chronic cough that was either 2 weeks or more were not seeking care in the facility. So when we looked at this, of course, with other scholarly data, we decided now to come up with some strategies, because we realized maybe we needed to do an intervention. And so that is why we piloted. This was a pilot study. We piloted this study in 4 health facilities. Yeah, so basically, in terms of what we did, was that we used a human-centered design. I think Professor Bruce alluded to it even earlier, where we involved the adolescents as we were designing. What we did, of course, we had a company, a designing company, and that was, quite expertise dealing with the adolescents. And so we designed a package for intervention. We had quite a big number of items that we had to do, but in 2021, when we did this study, that is the time we had COVID. So with COVID restrictions and the outbreak, we were not able to implement many of the interventions. But then we came up with 3. The screening cards for TB, we had the posters for TB, and then we had a song that was designed for adolescents. Of course, all these had messages for TB. Now, what happened was that the screening cards were actually developed in a way that they had 4 questions, the usual 4 questions that we ask our TB, suspected patients. Issues of fever less than 2, weeks, 2 or more weeks. Intended maybe intentional weight loss, and then also drenching night sweats, and yes, and cough of 2 or more weeks. Yes, so basically that is what we had in the card. Now this card, what we did was I wanted to emphasize this more, and then we'll run through. Now what we did with the card was that we identified adults who came to the clinics. First of all, those ones who came to the TB clinics, who had TB. So we then identified those. Then also the ones in other entry points that still had signs and symptoms suggestive of TB. So we identified them. And then these were people who the health workers trained to go and screen their own adolescents at home. It was like more of a contact tracing. And it somehow, it really worked. Then the poster messages, we also worked together with the VHTs who took these poster messages to the hotspots where youth were normally seen to gather. And then we had a song that was played over the radios. We tried to pick on radios, trying to cut across the villages and pass the song. So this was done prior to the enrollment. So then after that, we now enroll the people, the youth, the adolescents who came to the facility. So we did this in Kaolo Hospital, Iganga, Gombe, and Chioko. So you'll realize one set was urban, one set was rural. Yes, and then also what we did, we collected the social demographics, the age, the sex, and education levels, and all that. The clinical characteristics of TB, yes, to understand their, knowledge on TB, whether they knew TB, adolescent TB, the importance of coming to screen and all that. Then after that, we decided that to have us assess the impact of this intervention, we collected the before and then the after intervention data. Now, these were our results. Results really came out good. We were able to enroll that time 394 adolescents. And then, of course, we realized a majority of them were school-going children. And then, so the average number, of course, adolescents screened that time increased according to the analysis, and the increase was statistically significant. We had incident rate ratio of 1.9, that was almost a twofold increase, because of the intervention. And then also those presumed to have TB, there was also more than a twofold increase, which was statistically significant. Then when it came to the tested, yes, there was also a more than threefold increase, which was statistically significant. And of course, now still we didn't register many that were positive. That's why we are saying there was a minimal increase, which of course in those tested, and it wasn't statistically significant, as well as those that were linked to care. Of course, when there are few that are positive, it's, automatically that there maybe probably few. So, generally speaking, what happened is that the intervention really improved the uptake of care among the adolescents. We saw the number of adolescents coming, and right from the level of screening, yes, from screening and testing and all that. And of course, we therefore recommend, since it was a pilot study, we recommend that we could probably do a bigger study, because like as I told you, we could not reach maybe other places like schools and what, and yet we had different intervention methods for different categories. So I want to, as I conclude, just to appreciate our team that put this together, and then of course the managers of the health facilities, the health workers that we worked with, the research assistants. We also had study volunteers, the VHTs, and Design Without Borders was actually the designing company that we used, that designed this together with the youth. And then our special thanks to Makerere University Research and Innovation Fund that facilitated the study, MLI, Administration, and Ministry of Health, specifically the National TB and Leprosy Program. Thank you.
I'm Praise Gifta Katukunda, and I'm a biostatistician at Makerere University Joint AIDS Program, but working under Chirudu National Referral Hospital, and a data analyst for MAC-BRC. So today, I'm not going to present actual statistics for today, so don't expect a lot of statistics in my presentation. Like Dr. Ivan said, to go off scientific presentation. After doing this analysis on factors associated with different variables in data, looking at the combi methods and multivariable analysis, etc., all those results, what can be done to bridge those gaps? So today let me introduce to you my topic of using multi-component quality improvement interventions to reduce inpatient TB HIV mortality. Okay, the background, tuberculosis is the leading cause of mortality among hospitalized patients living with HIV. In Uganda, over 50% of deaths are attributed to HIV. That's the World Health Organization report, which was out in June 2023. At Children's National Referral Hospital, the TB HIV inpatient mortality was 29% between July 2022 and September 2023. So now today's question is, what is the role of quality improvement interventions to reduce TB-associated mortality among these patients? So the methods we used, we conducted a root cause analysis to determine causes of high inpatient TB HIV mortality, and this was by a multivariate analysis, and we identified those factors. So the next method was a root cause analysis by brainstorming and having key informant interviews using open-ended questionnaires of clinicians who interact with TB patients specifically. So there were 12 clinicians. After the questionnaires, we had a fishbone problem analysis. For those of you who have interacted with it, the head is the problem, then other 5 whys are used to identify why the problem is happening. So the key interventions were prioritization matrix, where we identify the gap of the problem, then we see its feasibility and affordability, because every QI is supposed to be affordable. We use a scale of 1 to 5. Then we had a QI target outcome after identifying or forming. This is a step of teamwork, forming. At the step of forming, we had a QI target outcome to halve the number of TB HIV deaths from 29% to 15% within 9 months. So the monitoring of these interventions was applied on a quarterly basis, while QI meetings and the monitoring of the indicator was done monthly. So the identified barriers out of these discussions were 4. Majorly 4 areas were prioritized, and these were a lack of standard operating procedures on inpatient TB HIV management. Then another gap identified was patients who present with poor functional status. That's the Eastern Cooperative Oncology Group, ECOG score 3 to 4. So this is similar to the Kanovskis, if you are used to that. But we use the ECOG score because it's a high volume facility, Children's National Referral, and it would be better for us. Then we also had long turnaround time results in the laboratory and late TB diagnosis. So after identifying the problem and how did we prioritize the interventions? We used the QI multi-component implementation strategy by formalization and disseminating SOPs to guide clinicians on inpatient TB HIV management. Then we had conducting of CMEs, or what we call continuing medical education sessions for capacity buildings on inpatient TB HIV management. Another strategy was use of a MUSE score, or modified early warning score, as a new triaging system. So in this system, we identify, it was done to ensure that patients who are later referred survive. And then we had intensified screening of TB using CD4 cell count and use of RAM strips to reduce the long turnaround time results in the lab, and one-on-one mentorships on inpatient TB HIV management. However, as the staff kept on increasing, we used the mentorship of mentors. So we mentor people to go and mentor others in managing TB HIV. So this graph shows the results on how these interventions were done and what came out. We can see in the first quarter, after disseminating SOPs, conducting CMEs, and use of MUSE scores, we had a reduction of TB HIV mortality from 45% to 25%, and finally to 15% in the last month of the quarter. Then after this, we added in more strategies. Like I said, it's a multi-component model, which was intensified CD4 testing and malnutrition screening. as we know, TB is active in malnourished patients. Then we also had we actually had an exponential increase in TB HIV mortality at 37% when the interns completed their rotation. There were labor gaps at the hospital. But this was also presented, and we had to recruit volunteers to take on the roles, and we had a further reduction in TB HIV mortality. And by the end of our set month, we had achieved our 15% coverage, and it further reduced to 13% by July 2023. So as I conclude, we can see, according to the graph, we can see that TB HIV mortality was reduced from 45% to 13%. Then our recommendations is quality improvement approaches in inpatient management mortality is key and prior. We also recommend phased implementation of viable interventions with proper monitoring strategies, to strengthen bridging of health gaps. So maybe as I conclude our take-home message, from the beginning of the sessions, my last presenters, we had how simple things were used to actually save lives. The Honorable gave a mask to one of the patients who came complaining of lung issues. So we can do simple things. We just need to identify the gaps that we have at a low cost, and we can have results achieved. Thank you so much.
I can say that all of this evidence that you've presented to us, we've either started using it or we are going to use it. For example, we now have a TB HIV mortality collaborative that is using these results. So thank you for this work that you've done. I take the opportunity to invite Dr. Misachi to chair the next session.
So the first presentation is coming from Dr. Alex Kayongo, sputum microbiome and chronic obstructive pulmonary disease in rural cohort of well-controlled HIV infection. I think this is what it's here. So Dr. Alex.
Hello everyone. My name is Olive Namakula. I'm a research fellow at Makerere University Lung Institute. I would like to take this opportunity to welcome you all once again, and thank you for being patient up to, I think, 6. We've heard a lot about the different lung issues, so it's time to hear a bit about some COVID. This study characterized patients presenting with COVID-19 related symptoms following national rollout of COVID-19 vaccination in Uganda. Okay, as a way of background, characteristics and treatment outcomes of COVID-19 patients in the different waves of the pandemic have been characterized and described globally. However, fewer studies have characterized patients presenting with COVID-19 related symptoms following a rollout of vaccination. Also, characterizing patients presenting with COVID-19 related symptoms gives us a comparison group in order to better understand how COVID-19 relates with other acute respiratory illnesses. So this study aimed at characterizing patients presenting with COVID-19 related symptoms following national rollout of COVID-19 vaccination in Uganda. This is a sub-study. It was nested in a prospective study that assessed effectiveness of COVID-19 vaccination in Uganda. The parent study used a test negative case control design, and it enrolled 6,606 adult patients. So for this sub-study, we looked at all these 6,606 patients. The patients included SARI patients and non-SARI patients. SARI is a WHO definition for a severe acute respiratory illness. These are people hospitalized with acute respiratory illness with fever that is either documented or present and a cough. We included patients that had symptoms for at least 10 days, not more than 10, and hospitalization was at least 24 hours in the hospital. We also included non-SARI patients. These were outpatients that had a COVID-19 test. They had either come for the test because they had at least one of the cardinal signs of COVID-19, which was cough or fever, or they had been referred by another health worker, but these are outpatients. 10 facilities were purposely selected to ensure representativeness. We had 8 public facilities and 2 private facilities. We had Mulago National Referral Hospital, and we had Soroti, Arua, Moroto, Mbara, Hoima, Gulu Regional Referral Hospitals, Kisoro District Hospital. We also included 2 private facilities to represent the high socioeconomic status class. We wanted a good representation. So we also included Nakasero Hospital and Zambia. So all patients that were enrolled had a COVID-19 test done, regardless of if they had had one done before. So these are the social demographic characteristics of the people we included in the study. We found that of all the 6,606 patients, only 250, which is 3.8%, actually tested positive for COVID-19. The 96.2% tested negative. The mean age was 39.4. Majority of the participants were aged 25 to 34. This was overall, and also among those that were COVID positive and those that were COVID negative. Those that were COVID negative also had acute respiratory illnesses, so there were other acute respiratory illnesses other than COVID. The most prevalent occupation was peasant farming, and to note, overall there were only 1.7% healthcare workers, and among the COVID-19 positive patients, there were 9.6. So at bivariate analysis, we found that compared to other occupations, healthcare workers were more likely to test positive for COVID-19. The symptoms didn't differ much from among those that had COVID-19 and those that had other respiratory illnesses. Although also to note, from our inclusion criteria, cough and fever were part of the inclusion criteria. So they were the main presenting symptoms, but they were part of the inclusion criteria. So I won't dwell much on that. The most prevalent comorbidities were hypertension, DM, HIV, chronic kidney disease, TB, and asthma. And this trend was the same among those who had COVID-19 and those who had the other acute respiratory illnesses. Females were more likely to test positive for COVID-19 compared to males, but this was at bivariate analysis. I've talked about the health workers. And then also compared to other comorbidities, patients with chronic hematological conditions were more likely to test positive. I also put the factors that were significantly associated with testing positive for COVID. Overall, we had chronic hematological diseases and sore throat and loss of smell. Then among the patients with severe acute respiratory illnesses, we had chronic hematological conditions and joint pains. Then among those that whose severe acute respiratory illness wasn't severe, it was those that presented with loss of smell and sore throat that had a higher chance of testing positive for COVID-19. As a way of concluding, when we compared the pre-vaccination cohorts and the post-vaccination cohort, we realized that overall, for studies that have studied patients presenting with COVID-19 related symptoms, majority tend to test negative actually. But when you compare the pre-vaccination cohorts and the post-vaccination cohorts, we found that very few participants among the post-vaccination cohorts test positive. So that is 3.8% compared to the 30% for the pre-vaccination cohorts. So this just really adds to the available scientific evidence of the benefits of the vaccination, that much needed intervention. Another key issue that we noted is that despite health workers being prioritized for COVID-19 vaccination, they were more likely to test positive for COVID-19 compared to the other occupations, although this was at bivariate analysis. One would argue that this is because of exposure dynamics, given the fact that COVID-19 patients will come to the health workers, so they are more exposed. But also, one would argue that these people know about the disease and infection prevention, and so they would be expected to institute infection prevention measures. So this is just to all of us. While we take care of the people in the mines and the people on the roads and everyone else with the sawdust and all those other occupational hazards, we may be forgetting about ourselves. Looks like we are ignoring some of these occupational hazard SOPs ourselves. So that is key for us. And then when we compared the prevalence of the comorbidities, well, for this particular cohort and the general population in Uganda, we found that we had lower percentages of hypertension, DM, chronic kidney diseases, and asthma. And also when we compared the post-vaccination and the pre-vaccination cohorts, we found that the post-vaccination cohorts have lower percentages of these comorbidities. So is this because these people know that from the first data, from the first COVID patients, they know that people with comorbidities are prone to more severe forms of the disease and worse outcomes, so they are actually taking the precaution, they are being more conscious and observing the SOPs and making sure they stay away from COVID, unlike the health workers who are still more likely to test positive. Then the other issue that stood out was, apart from chronic hematological diseases, the rest of the comorbidities did not differ statistically by COVID-19 status. That is it from COVID group. Thank you.
I'm going to talk about a topic which is slightly different from occupational lung health. It's about what happens at the airway mucosa to orchestrate what eventually brings all of us here: lung fibrosis, scarring, reduction in lung compliance, and the symptomatology of COPD and other occupational lung diseases that eventually reduce the quality of life of people in Uganda and the world at large. So to cut down the scope, I'm going to use the case of COPD and see how changes in the bacterial communities that inhabit the airways of these individuals orchestrate inflammation that results into fibrosis and then genesis of the respiratory symptoms that bring patients to the clinic. So in this perspective, I'll concentrate on people who are infected with HIV/AIDS as a case for today. As a brief introduction, we know that increased access to ART has really done a significant contribution in bringing down HIV-related mortality and morbidity. And we see that as more people access treatment, their life expectancy is increasing, so they become susceptible to the known risk factors for NCDs. And in this perspective, we will narrow down to the COPD. So that improvement in life expectancy brings in the challenge of increased susceptibility or risk to NCDs, including COPD. So what you're seeing here is a comparison of the incidence of COPD in the HIV versus non-HIV in the pre-ART, ART, and late ART era. And you can see when you compare the HIV positive and the negative, there is a clear-cut difference between the cumulative incidence of COPD, meaning that HIV has a role it plays in orchestrating lung inflammation and resulting into COPD pathology. And on the right, it's just a representation of one of the histology slides showing you a normal histopathology of the airway, having really nice air sacs completely free of fluid or any inflammatory processes going on. In B, you can see that as a person develops one of the phenotypes of COPD, it can either be chronic bronchitis of the emphysematous form, but in B, you see it's chronic bronchitis with deposition of the mucus plug that reduces airflow in these patients. And in C, you can see that you can also have a phenotype of inflammation where you have increased infiltration of cells like neutrophils, lymphocytes, which orchestrate inflammation result into damage caused by mostly attempt at healing, which doesn't really work. So you have extensive fibrosis, bronchoconstriction, and reduction in the flow of air. Particularly in the COPD patients, they can have success in bringing air to the air sacs, but they find it difficult to draw out that air out to the environment. So there is usually air retention, and specifically we know CO2 causes a major problem in these individuals when they fail to bring it out. So here, I looked at a cohort of individuals in Akaseke to try and see if changes in the microbial communities really impact COPD immune homeostasis, to see if it actually contributes to the immune inflammation that happens in these participants. So specifically here, we targeted groups stratified by HIV and COPD and recruited 50 individuals in each, and then did sputum induction in all the groups, obtained sputum, and did downstream analysis to quantify the microbial communities that inhabit the airways of these individuals. So to just cut the whole story short here, we used advanced bioinformatics tools to try and identify compositional differences in individuals who were having HIV or COPD in the 4 groups. What you're seeing here are the major clusters of populations we discovered in these individuals. So some were predominantly having organisms belonging to the genera Streptococcus, others have a mixed phenotype, all others had Prevotella predominating these airways. And when we looked at the differences in the distribution of these types, we found that HIV was actually a major driver in the spatial differences in the distribution of these communities across the 4 groups. And then here what you're seeing are diversity scores that indicate how different the bacterial communities were in the 4 groups. So when we did statistical comparison, we didn't see a much clear difference statistically between the 4 groups, indicating that despite minor differences in the genera, there was some kind of heterogeneity, which maybe was attributed to the fact that all our patients were coming from the same population. But nevertheless, we applied more sensitive methods to underpin signatures that we are driving inflammation in our population. So what you're seeing here is application of an advanced bioinformatics pipeline and analytical algorithm called MetaConfounder R, where we looked at typical signatures that we are driving inflammation in our population. And what you see there presented in the heat map with little stars where the statistically significant hits that were orchestrating inflammation in our patients who had HIV and COPD comorbidity. And we tried to summarize most of the significant hits in the pseudo-volcano plot illustrated in figure C. And finally, I conclude the presentation by stating that we successfully phenotyped the microbiome profile in our population, and we clustered the communities into 3 palmotypes, which were significantly impacted by HIV. But most interestingly, we see that when you compare the effects of COPD and HIV, it's as if HIV was actually driving the changes in the microbiome, which eventually were driving immune inflammation that we are working on in our second project. And out of all the organisms, that organism ranked number 1, which is Campylobacter, usually dysenteric, but we found it predominant in the airways of people who had dual HIV and COPD status. Thank you very much for listening.
So, ladies and gentlemen, allow me at this point in time to invite the Director, Mubende Regional Referral Hospital, Dr. Batiwe, who I know personally from the pandemic, not pandemic, but from the epidemic that we had in Mubende. So, Dr. Batiwe, please come and give us your remarks and do us the honors of summing up this symposium with closure. But as he does that, when it's closed, we are going to get a moment where we are going to cut cake, and I'll invite some of you to the stage here to cut cake with Dr. Batiwe.
Thank you very much, Dr. Ivan. First of all, I would like to recognize all of you in your different capacities, particularly the time you spent here in this very significant second lung science and health symposium. I would like to thank the organizers, Makerere University Lung Institute, Makerere University College of Health Sciences, the National Tuberculosis Program, the Minister of Health, and all other donors who have been able to put together resources to have this very beautiful symposium. We also like to thank the eminent presenters. These guys have done a tremendous job, and I'm sure you bear witness that you've been able to learn a lot when you are here, right from the issues concerning lung cancer to issues of occupational lung diseases, which have been presented by different people, the experiences of people with severe pneumonia in children, and other associations with HIV. We've talked a lot about the chronic obstructive lung diseases, as well as the air pollution and its relationship with lung health, of course, including tuberculosis. So we really thank you. You've really tickled us a lot in realizing that we have a very big burden of lung diseases which are associated with environmental or occupational causes. And strikingly, as they were presenting, I kept realizing that there's a lot of relationship with pollutants. And this is significant. You can't run away from the fact. And it reminds me of the free app which is on Google. Google Store has a small air pollution free app, which uses satellites and centers located in many of these embassies in Uganda, Kampala Embassy, the Nairobi Embassy, the Kigali US Embassy. There's a way they monitor our air pollution. And actually, if you travel from one country to another, you begin seeing the difference we have. I was showing it to my neighbors I was sitting with there, and it was showing that we are in an unhealthy assessment. You know, if you look at that where we are, just air pollution alone, it is really, really high here in Uganda. I've been to other countries. I've been to Beijing, I've been to China in Beijing, I've been to Japan, Tokyo, in about the same time, just before COVID broke out. And their apps, here ours were dark red, orange at best. Theirs were light green and blue, meaning their particulate and other fumes, pollution in the air is really low, it's well controlled. And clearly, I think we can emulate them. And I think there's a big association with the pollutants and lung disease, as you know. So, and one of the presenters talked about mercury. It tickled me. I don't remember whether dental surgeons are still using dental amalgams. Are they still putting them in our teeth or not? I kept thinking. Sometimes what I learned about these pollutants is that they don't really just appear directly in the lungs, but they can also appear in other organs. They have a preference for certain organs, and for some reason they are there. And then you find maybe someone was having a pollution maybe coming from benzene, which is another very interesting pollutant around. Every product you see, it has benz, yet they have abolished the use of benzene. And also isopropyl alcohol, which is also closely linked with the cancers. And these are very much in many of our products. But those are areas all of research. But significant for our air pollution, we should begin with the policemen. These are the guys who are, all of you see these motorcycles going in front of you, and they have all this big fume of following it, and you're also following, inhaling, and you say nothing about it. And these policemen are there stopping you, doing that, checking different things, and then the vehicle sets off and leaves me a huge puff of pollution in the exhaust waste. I think let's begin, I request the Lung Institute to give special training sessions to the police so they can be able to help us implement or enforce the compliance to the standards and guidelines that may have come out of the research you have done. It will be, I think, a very good approach to help us diminish this significant pollution we have in our country. Of course, it eventually finds its way into the water we have and everything that we use. So the research which is done by Makerere University Lung Institute can be extended to regions. The regional referral hospital, one of which I head in Mubende, have research and ethics committees which can quickly go through your proposals, however simple they are, and can carry out and help even carry out the research in these regions. I've been seeing most researchers who are carried out around Kampala, Mulango, Kampala, and there are other regions also, there are hospitals there. So please, I invite you on behalf of other facilities, come and do the research there. You will be greatly welcome, and I'm sure when we do this, we shall be able to support evidence-based legislation, standards and guidelines, so let us support the Lung Institute grow. So with these few remarks, I would like to take the singular opportunity to have this symposium, the second Lung Science and Health Symposium, closed. Thank you very much.
Okay, so we are going to count from 8, and when we reach 0, we shall, I don't know which song you people sing at birthdays, but that's what we shall do. 8, 7, 6, 3, 2, 1, 0. The portals have